Hello, and welcome to today's Symposium, a Symphony Academy medical education event brought to you by Circle Cardiovascular Imaging. My name is Rachel Tursick, a Global Training and Education Manager at Circle CVI. Today's session will cover advanced CT imaging and structural heart disease. Please note that there will be a live Q&A session at the end of this talk, so if you do have any questions, make sure to put them into the chat window, which will be monitored by our staff throughout the session. Without further ado, I'd like to introduce our speaker for today's talk. Dr. Jonathan Leipsic is the chairman of the Department of Radiology for Providence Healthcare, Vancouver Coastal Health, and the vice chairman of research for the UBC Department of Radiology. He is a professor of radiology and cardiology with the University of British Columbia. Dr. Leipsic is also a Canada Research Chair in Advanced Cardiopulmonary Imaging. Dr. Leipsic has over 360 peer-reviewed manuscripts in press or in print, over 300 scientific abstracts, and editor of 2 textbooks. He speaks internationally on a number of cardiopulmonary imaging topics with over 150 invited lectures in the last 4 years. He is also the past president of the Society of Cardiovascular CT from 2015 to 2016 and was awarded its gold medal in 2019. And was recently named to the prestigious top 1% most impactful scientist designation by the Web of Science in 2019 and 2020. So without further ado, I'll pass the talk on to you, Dr. Leipsic.
Thank you again for the introduction and the opportunity. I'd also like to thank the sponsor, Circle Cardiovascular Imaging, for not only supporting this symposium, but supporting the SCCT really for the last decade. Your support is tremendously appreciated. I'm going to try and focus over the next 15 minutes on advanced CT applications for structural heart disease, and less so in the aortic space, but really about how we use modern workstation tools and advanced software algorithms to advance our understanding of risk of procedures and help to plan transcatheter interventions. I do have some disclosures that are salient. Most relate to the core lab work we do for a lot of structural heart disease trials for which I take no compensation. I am an advisor to Circle Cardiovascular Imaging, although took no compensation for this talk. So, we could start off with the clear role of CT to help support transcatheter aortic valve replacement. We could also highlight that in the modern day, particularly with the publication of the 2 low-risk randomized trials in the New England Journal in 2019, that TAVR has really disrupted the management of severe symptomatic aortic stenosis. And in fact, we've also seen the field moving towards asymptomatic population and even moderate AS with heart failure. And so TAVR and transcatheter heart valve interventions are clearly here to stay and will continue to grow and evolve. As it relates to the valves beyond the aortic position, we're learning a lot more about mitral and tricuspid interventions, obviously going beyond the scope of this talk, which is really just focusing on how we use advanced CT tools to help plan procedures. But what we see here from the very elegant state-of-the-art paper in JACC just this week, I guess since this is recorded, what week is this? The 15th of June. There's a nice review from the Quebec group talking about the evolution of transcatheter mitral intervention, showing that they're not only feasible, but can be quite effective with a high technical success rate, but also highlighting that there are residual complications that I think we need to focus on, and we need to help our interventional colleagues with advanced imaging tools to help reduce their procedural risk. These are data that were presented at PCR by David Muller from Sydney, and I believe is now in press in JACC, the 2-year outcome of the Tendyne data, again highlighting that you take patients with severe mitral regurgitation, you do a transcatheter mitral valve replacement, and you can eliminate mitral regurgitation. And that reduction in mitral regurgitation is durable out to 2 years, as is the clinical improvement with reduction in heart failure symptoms. Obviously, patient selection, identifying which patients will derive benefit, which patients will derive benefit as compared to remodeling or TEER procedures, so-called, or clipping procedures, remains a challenge. But I think what we do know is that if we screen our patients correctly with CT, our interventional colleagues can have a very high procedural success rate and be successful in eliminating mitral regurgitation. To do so, though, we know that we need CT. We need CT because it really provides us a unique opportunity to characterize the landing zone of the transcatheter heart valve as it relates to defining the procedural landing zone and the coaptation for the transcatheter mitral valve. Using basic CT tools, we know that we can recreate the D-shaped mitral annulus, such as this case. But we've also learned about 30 years ago that the mitral annulus is, of course, non-planar, and it's really saddle-shaped. And originally, we thought this would be a challenge for CT workstation tools, but you know, a number of companies, including in this case Circle, have facilitated tools that allow us to more reproducibly and confidently segment the saddle-shaped annulus. Here we can see segmenting the annulus and recreating the saddle-shaped configuration defined by the posterior shelf at the junction of the posterior leaflet insertion at the junction of the atrial and ventricular myocardium, and then the saddle anteriorly extending up to the root of the aorta. Of course, over the years, we've started to really understand how to use these CT-based measurements, and I think what we've seen both from our core lab work as well as work from many others, including Joel Cavalcante and Didi Wang and others, that these measurements are highly reproducible and highly effective in sizing the landing zone for transcatheter mitral valve devices, as we see on the left. But what we've also learned is by integrating things like STL files from the specific device, in this case it's a Tendyne device from Abbott, we can actually model the intended implantation and evaluate the personalized patient-specific risk of LVOT obstruction. Our group, along with others, put together a recent state-of-the-art paper in JACC Imaging trying to understand the role of CT and better define it as it currently stands. And I think what we know is that there's more that we need to learn. We need to learn from post-implant imaging about the remodeling of the devices to better understand how our pre-implant LVOT prediction relates to the post-implant LVOT measurements. We need to understand how procedural and device canting can impact this. Residual or remodeling of the ventricle may impact LVOT obstruction. But despite all of these limitations, when I think of how far as a field we've come in the last 5 years, when the very concept of the neo-LVOT wasn't even established, I think we can all be proud that we in the field of cardiac CT have very much contributed to an understanding of procedural risk and have helped the development of this procedure by providing more robust screening of patients. Now, the LVOT, and it goes beyond the scope of this discussion, but the neo-LVOT, of course, needs to be characterized and sized in a different fashion if you're doing a mitral valve and MAC versus a mitral transcatheter mitral valve implantation for mitral regurgitation, or in this case, if you're doing a valve and ring or a valve and valve. If you're doing a valve and valve or considering a valve and MAC, and should the proceduralist be capable or familiar with doing a lampoon procedure, clearly things like the skirt LVOT become relevant. And these CT workstation tools allow us to actually adjudicate the skirt LVOT by really defining the expected covered stent in the location of the LVOT, defined by the actual skirt, so-called, of the transcatheter aortic valve in this case. Now, what we know is, and in fact, sorry, this slide says in press, but it was published actually in early 2020, work from Sang-Eun Yoon and Raj Makkar would suggest that the neo-LVOT by CT is not only interesting and potentially impactful, it is the single most predictive measurement as it relates to the prediction of post-implantation LVOT gradients. And so being able to evaluate the CT in a robust fashion is really essential in understanding personalized risk. And again, that risk, and you can see here when the neo-LVOT was below 1.7, the risk of gradient post-procedurally was significantly elevated as compared to when the neo-LVOT baseline CT was greater than 1.7. And this held true over valve and valve, valve and ring, and valve and MAC. Now, challenges, of course, as it relates to segmentation are greater in the setting of MAC. We know that MAC is irregular. It is inconsistent in its counterbearing forces. It has varied density, and it's challenging to segment the landing zone. That being said, I think advanced analytics and also with integration of AI over time will allow us to link outcomes to pre-procedural segmentation, and to allow us to be much more reproducible with regards to the segmentation of our landing zone. We do know, while that evolves, that we have some data from Myra Guerrero and colleagues from Mayo Clinic, really understanding how to characterize the landing zone and predict the risk of embolization. In this case, one can see that when the calcium is greater than 10 millimeters in thickness, if we look at calcium thickness, circumferentiality, trigonal involvement, and leaflet involvement, it helps us understand those patients who are at risk of embolization, with lower scores being at significantly heightened risk for embolization as compared to those with higher scores. And in addition, as we've seen here, this is a case from our site modeling the pre-implant valve and MAC expected neo-LVOT using a virtual implantation in the neo-LVOT from CT, and then looking at the post-implant residual LVOT and seeing the nice agreement in this case. So these are fundamental tools that are really essential for us to be planning these procedures. Now, something we don't talk about as often now, but I think it's a real opportunity with our advanced workstation tools, is to really understand the opportunities of using CT for implantation, fluoroscopic angle assessment. You know, we've learned over the years that in the aortic position, this was quite relevant to ensure that we had a coaxial deployment of the transcatheter heart valve to mitigate paravalvular regurgitation, to reduce pacemaker risk, as we've seen recently from the Cleveland Clinic group. And none of this is new, and certainly for the aortic valve, it's fairly straightforward. For the mitral, it's obviously quite different, because we're not looking just to be coplanar to the landing zone of the annulus, but rather we may want to be coplanar or coaxial to the TT line, or the septal to lateral, the so-called A2P2 line. And that's more challenging for us to do with just routine multiplanar reformats. We really require these more advanced integrated tools that provide us fluoroscopic angles across the host of potential working angles for the procedure. Here you can see the commonly desired but rarely achievable caudal commissure to commissure view, or TT view, which is deeply caudal in RAO, and then the more acceptable but somewhat less desired A2P2 angle of RAO and cranial 33. Now, these angles, of course, can be provided once we segment any three-dimensional landing zone with CT, whether it's the left atrial appendage, pulmonary veins, the atrial septum, the mitral annulus, the tricuspid annulus, and so on. Using these advanced workstation tools, we can generate S-shaped curves that are personalized to the patient's specific anatomy and help inform our proceduralists as to the working angles that may be of benefit for her and her procedure. If we also consider that there may be some reason to understand the location of the coronary sinus as it relates to the landing zone, and having some understanding of the depth may be of value, because they often put a wire in the coronary sinus to define the mitral annular landing zone, then being able to understand the depth of the mitral annulus or the coronary sinus from the mitral annulus would make sense. And of course, we can map that out, and have shown that a number of years ago, to provide personalized understanding of the distance between P2 and the coronary sinus. Of course, we can do a lot more than just the landing zone. We can generate images that are very similar, and this is lent to me by my friend Nico Piazza, using a technology called FluoroCT, which is integrated with the Circle package. Technology that really was built by interventionalists to understand how to guide procedural intervention to optimize fluoroscopic angles such that they achieve traditional echocardiographic views, which are helpful, of course, as you're guiding the procedure both by TEE, but also understanding the procedure as it evolves. And so what Nico is showing here, of course, is that there are a number of traditional echocardiographic angles or projections that are traditionally were not achievable in the cath lab, because there was a lack of awareness of how to actually optimize your angle to achieve that. But now, of course, with CT, we can map these things out in advance and really then provide our procedural colleagues the optimal fluoroscopic angle to achieve the 2-chamber, the 3-chamber, or the 4-chamber view. And we can do this, of course, in the calm, cool, collective room of the structural heart rounds rather than at the time of the procedure. We can even help segment, as has been shown again by the McGill group a number of years ago, mitral valve segments to help optimize the fluoroscopic angle based on CT to optimize the projections, whether it's a short axis, the 3-chamber, or 2-chamber view. So I think that these opportunities, we're just scratching the surface. I think the opportunities continue to evolve, and how we integrate these into our procedural planning, I think we will continue to learn over time. I wanted to close for the last couple of minutes about understanding hypoattenuating leaflet thickening, and clearly CT is the gold standard for this. Not everything that's dark on the valve, of course, is halt. You can have pannus or thrombus or calcium. But we've known for a number of years that halt is not uncommon. It's probably slightly more common on transcatheter valves than surgical bioprosthesis, but this is really an issue of bioprosthetic valves. CT is the gold standard for its diagnosis. It's not that we should be pursuing it in the absence of symptoms, but certainly if someone has a rising gradient, has a stroke, or peripheral vascular event, or has a new onset heart failure, CT can be a very elegant tool to characterize things such as this, restriction of leaflet motion, but that is primarily an echo-based segmentation. The goal of CT is, of course, to look for the halt. Halt is meniscoid, thickest at the base, extends to the tip, and thins out. These are the classic features. We can characterize them and identify them routinely on CT on all of our workstation tools. We provided guidance through the SCCT. We really think this should be an ordinal scale, the extent of the leaflet involvement, the number of leaflets that are involved, so a total score of 12, 4 for each leaflet. Now, keep in mind, the reason we need workstation tools that I think are not overly simplified, that are still meant for imagers, is that we shouldn't just go in with an assumption that we're going to find halt and reconstruct the images solely to look for halt, because there are, of course, other things that can cause hypoattenuation, such as this case, where we have a circumferential hypoattenuating material, but extending below the leaflets and not limited to the leaflets, and not simply meniscoid extending from the base of the leaflets, but rather in this case pannus. Here you can see an example of circumferential pannus again. As well in this case with infective endocarditis or symptoms suggestive of it, fever, sepsis, the patient has a focal area of thickening at the tip of the leaflet, not thickest at the base. This is not in keeping with halt. This is in fact vegetation. How common is halt? We know that it's approximately occurs anywhere from 10 to 20% of the time. These are data from the low-risk trials from Medtronic above and below from the Edwards data, and it would show that the rates of halt are fairly similar between devices and between surgery and TAVR, perhaps slightly higher in TAVR. But what's fascinating is that we've learned over the years, of course, that halt goes away with anticoagulation. But interestingly, as we saw in the late-breaking data by Raj Makkar and then published in JACC, that sometimes halt, which was identified at 30 days, goes away without anticoagulation. But similarly, when there's no halt at baseline, sometimes halt develops between 30 days and 1 year. So we're really just scratching the surface. There's a lot more to learn, but I'm confident that using advanced workstation tools, coming together with our procedural colleagues, and working together as a field, particularly the Society of Cardiac CT, we're well positioned to help advance our understanding of this and all of the complex challenges we're faced with in the transcatheter valve intervention arena. So thank you again for the opportunity and for your attention.